Hello and welcome. Today, we'll be discussing infiltrative cardiomyopathy, a heart condition where abnormal substances deposit within the heart muscle, interfering with its normal function. We'll explore the causes, effects, diagnosis, and management of this complex disease. Infiltrative cardiomyopathies arise when abnormal substances infiltrate the myocardium, the heart muscle. Amyloidosis is a prime example where misfolded proteins called amyloids deposit in the heart. Sarcoidosis, another significant cause, involves the formation of granulomas, clumps of inflammatory cells, within the heart tissue. Less common causes include hemochromatosis, where iron overload damages the heart, and other rare infiltrative conditions. The pathophysiology of infiltrative cardiomyopathy revolves around the disruption of normal heart function due to the infiltrating substance. In amyloidosis, the amyloid deposits stiffen the heart muscle, impairing its ability to relax and fill with blood properly, a condition known as diastolic dysfunction. This leads to reduced cardiac output and eventual heart failure. In sarcoidosis, granulomas disrupt the heart's electrical conduction system, leading to arrhythmias, and can also cause restrictive cardiopathy by stiffening the heart muscle. The inflammatory process in sarcoidosis can also damage the heart directly. Hemochromatosis leads to iron deposition within the cardiomyocytes, causing oxidative stress and cellular damage. The epidemiology of infiltrative cardiomyopathies varies depending on the specific underlying cause. Amyloidosis, particularly transthyretin amyloid cardiomyopathy, ATTR-CM, is becoming increasingly recognized as a cause of heart failure, especially in older adults. Cardiac sarcoidosis is more common in certain ethnic groups, such as African Americans and Japanese individuals, and often affects younger individuals. Hemochromatosis is associated with genetic mutations and affects individuals of European descent more frequently. The signs and symptoms of infiltrative cardiomyopathy are often nonspecific and can mimic other heart conditions. Common symptoms include shortness of breath, fatigue, swelling in the legs and ankles, and chest pain. In amyloidosis, patients may also experience carpal tunnel syndrome, peripheral neuropathy, or an enlarged tongue. Sarcoidosis can present with arrhythmias, such as heart block or ventricular tachycardia, as well as symptoms related to sarcoidosis in other organs, such as the lungs, skin, or eyes. The diagnosis may be delayed due to the varied presentation. Diagnosing infiltrative cardiomyopathy requires a comprehensive approach. An electrocardiogram (ECG) may reveal abnormalities, such as low-voltage QRS complexes or conduction abnormalities in sarcoidosis. An echocardiogram can assess heart structure and function, often showing thickened heart walls and diastolic dysfunction. Cardiac magnetic resonance imaging (MRI) is particularly useful for detecting infiltrative processes and assessing the extent of involvement. A definitive diagnosis often requires a biopsy of the heart or other affected tissue to identify the infiltrating substance. In suspected amyloidosis, a bone scan with radiotracer is useful to determine ATTR amyloid cardiomyopathy. Genetic testing may be needed, especially to determine the type of amyloidosis or hemochromatosis. While we generally refer to infiltrative cardiomyopathy as a single category, it is important to remember that it encompasses various specific diseases, each with their unique features. The most common are amyloidosis, including subtypes like L-amyloidosis and ATR amyloidosis and sarcoidosis. Less common types include hemochromatosis and Fabry disease. Distinguishing between these specific types is crucial as the treatments and prognosis can differ significantly. Treatment and management of infiltrative cardiomyopathy depend on the underlying cause and the severity of the heart condition. For amyloidosis, treatment may involve chemotherapy to reduce amyloid production in AL amyloidosis, or medications like tafamidis or diflunisal to stabilize transthyretin in ATTR amyloidosis. Heart failure medications such as diuretics, ACE inhibitors, and beta blockers can help manage symptoms. In sarcoidosis, corticosteroids or other immunosuppressants are used to reduce inflammation. An implantable cardioverter, defibrillator ICD, may be necessary to prevent sudden cardiac death in patients with arrhythmias. In hemochromatosis, phlebotomy to remove blood reduces the iron concentration. Heart transplantation may be considered in severe cases that do not respond to other treatments. Preventing infiltrative cardiomyopathy is often challenging, as many of the underlying causes are genetic or idiopathic. However, early diagnosis and treatment of conditions like hemochromatosis can help prevent cardiac involvement. In sarcoidosis, managing inflammation in other organs may indirectly benefit the heart. For some forms of amyloidosis with genetic predisposition, genetic counseling may be appropriate. The prognosis of infiltrative cardiomyopathy varies depending on the underlying cause, the extent of cardiac involvement, and the response to treatment. L-amyloidosis typically has a poorer prognosis than ATR amyloidosis. Cardiac sarcoidosis can have a variable course, with some patients experiencing remission and others progressing to heart failure or sudden cardiac death. Recent research has focused on developing new treatments for amyloidosis, including drugs that directly target amyloid deposits. Advanced imaging techniques, such as cardiac MRI with late gadolinium enhancement, are improving our ability to diagnose and monitor infiltrative cardiomyopathy. Clinical trials are also underway to evaluate new therapies for cardiac sarcoidosis and other infiltrative conditions. Thanks for joining us.